Hello, everybody. I am Stephen Kingsmore. I wish we were meeting in person, but we're not. I'm going to talk for the next 30 minutes or so about some really exciting things which are occurring in the field of neonatology that are poised to transform our approach to management of the fetus. I don't have a conflict of interest related to this presentation. Let's talk just for a second about our institute. We are very focused with two major goals. The first is to end the diagnostic odyssey for children with genetic diseases. The second then is to end the therapeutic odyssey, since many of those genetic diseases that we now diagnose do not yet have effective treatments. We are part and parcel of a change in medical care which has been evolving over the last 35 years or so, where we go from a one-size-fits-all approach to patient management, increasingly to the second panel from the bottom, where genome sequencing is being routinely used to provide a diagnosis of genetic diseases that then affect the precise management of conditions. And in the future, moving to the bottom panel, where not only do we get a genetic diagnosis, but we're also stratifying patients further than that based on other factors which influence rates of progression or disease severity, since in many genetic diseases, there's a very broad range of affectation. A couple of background slides just to emphasize this new world that neonatology finds itself in. First of all, we've had staggering success in identifying single locus genetic diseases. There are over 6,000 of those that are associated with genes, and there are about another 10,000 associated with structural variants across the chromosomes. And they continue to increase rapidly at about one a day, or 300 or 400 per year. And we now have a much clearer idea of the genetic underpinnings of many common presentations that affect both fetuses and newborns, such as, for example, congenital heart disease. We now recognize there are over 4,000 genetic conditions that can trigger congenital heart disease. And so we're starting to reclassify our thinking instead of common complex etiologies towards these individual genetic conditions, and to think through how we can treat these disorders based on those diagnoses. What we are finding is that this really is a phenomenon that's largely limited to maternal-fetal medicine and to neonatology, and to a lesser extent to pediatrics, that in fact, the baby's genome drives disease incidence, both at time of conception and then at time of birth. Obviously, at conception, we're looking at diseases, genes, which are critical for life and result in much fetal loss. And then again, at birth, for the first time, the baby's genome has to operate independent of mom's genome, and mom's genome has largely been compensating for many of those defects in the baby's genome. And so we have another massive uptick in the incidence of genetic diseases at birth. And just to substantiate that, this is some unpublished data that we have. We looked at 112 infants who died in San Diego County over the last 5 years, and for whom we had materials available to allow us to understand etiology. And the top pie graph shows the spectrum of causes of infant death before genome sequencing, and then the bottom panel, how we reclassify those once we understand genetic etiology. And I anticipate that the same is true of fetal loss. although I don't have yet a neat graph for that. But what you can see is that single locus genetic diseases are the leading cause of infant mortality in this cohort. And we believe this cohort is fairly representative of death in San Diego County and of death in the US. And that, in fact, many of these are not reported or recorded on death certificates. And so I anticipate that as we recapitulate this type of data, we will start to have a new view in terms of our understanding of the contribution of genetic diseases to fetal and infant morbidity and mortality. One last background slide, which is that it is now becoming not a costly thing to decode a human genome. It can be done today for about $600 in a research setting. And second of all, that time to diagnosis by decoding a genome can be very rapid. And so there's no reason why genome sequencing isn't poised to become as common in fetal medicine and in neonatology as, for example, ultrasound. So let me give you one case example where we use that 13.5-hour genome decoding to really illustrate how genomes are transforming the management of neonates, and I believe soon will be transforming the management of fetuses as well. So this little boy presented to our emergency department late last year, and the symptoms were those of early encephalopathy. He was inconsolably crying. He was highly irritable. He had subtle neurologic findings, and so we were concerned that he had a rapidly progressive encephalopathy, which had just started. His parents were consanguineous. They were first-generation Americans, and so we had a heightened awareness of the possibility of a recessive genetic condition. So he had a head CT ordered in the emergency department, and that showed what looked to all the world like hypoxic ischemic encephalopathy. But his mom had had a normal pregnancy. He had had a normal delivery. There was no hypoxia noted. And panels A through C show axial sections with an MRI of his brain the next day. And these white lesions, these white hypodense lesions, are what are suggestive of HIE, albeit it's not HIE, it's a condition masquerading as HIE. At morning rounds the next day, both parents are present, and we were able to elicit a full family history. And it turns out that he had an elder sibling who presented in identical manner 9 years earlier, before genome sequencing was available, and had died undiagnosed at 1 year of age of seizures and developmental delay. And her MRI images are shown on the right, and you can see how similar they are to her younger siblings. So we're now very concerned that this is recurrent and does indeed reflect a genetic condition. So on the basis of this, we get authorization for a rapid genome. We obtain consent from mom and dad to decode both their genomes and their baby's genome. We get blood samples from the trio, and they're moved over to our genome center, which is just across the street from the hospital. We're using new methods that can allow us to decode a genome in 13.5 hours. So we start the process at about 6 p.m. The library preparation is done and the sequencer is started at 7:30. 6:30 the following morning, it finishes the run, and we move into bioinformatics, which is driven by artificial intelligence. And that includes AI to extract the phenotypes of this baby from the electronic medical record. The AI takes about 10 minutes to complete, and we have a provisional diagnosis which is indeed an autosomal recessive disorder. He has a frame-shifting variant that's homozygous in the gene thymine transporter type 2. This is known to be pathogenic or disease-causing, and his diagnosis is biotin thymine responsive basal ganglia disease, which is a very good fit both with his clinical picture and his MRI findings. In the interim, while we have been doing this, he has started to have seizure activity on electroencephalogram. So these results are reported back to the neonatal intensive care unit, and then he is started on biotin and thiamine. And amazingly, within 6 hours, his irritability has resolved. He is calm, tranquil, alert, and bottle feeding. He goes home a couple of days later once mom has been taught how to supplement his feeds with biotin and thiamine, and he is now 7 months old and thriving. So just contrast there the picture 10 years ago in his older sibling who went undiagnosed and wound up dying of a genetic disease that was never diagnosed, versus Ryan, who has a prompt diagnosis, has treatment instituted within 36 hours of presenting, and probably will have a normal life. So that's the whole thrust behind this revolution in neonatology, and you can understand how impactful that will be at scale. This is the actual technology. I'm not going to do a deep dive on this, but the title of my talk is related to artificial intelligence. So let's just look at a couple of parts of that. So first of all, we order genomes the same way as any other test. It requires a small blood sample. We do use natural language processing to extract all of the phenotypic features of the illness from the electronic medical record. We prefer this to manual extraction of phenotypes because, unfortunately, clinicians are always thinking through their differential diagnosis, and therefore the features they record in terms of those at time of test order often reflect their differential diagnosis and can be highly biased. We prefer to be hypothesis-free when we use AI to diagnose genetic diseases. We have 3 available tools now from different organizations that can do an automated diagnosis based on HPO, human phenotype ontology, phenotypes and a genome sequence, or at least the VCF file, the variant call file from a genome sequence, from Fabric, from Invitae, and from Illumina. They each have different systems that perform fairly similarly in terms of their ability to diagnose based on these 2 data sets. I'll talk in future slides about an AI-based virtual assistant for clinical decision support. And then we use a critical result flag in our EHR system to make sure that we have a physician who reads the report and puts that note in the medical record within 60 minutes. So this is our system. It's highly automated. It's an end-to-end pipeline. And in the bottom, you can see the actual information flows. And I don't really need to go through that, but this is automated and scalable at this juncture. And as I said, possible in 13.5 hours. In terms of its performance, this is analytic performance, and we now have benchmark data sets that allow us to do this effectively. And so our precision and recall for small variants, nucleotide variants, is exquisitely good. Not so good for structural and copy number variants, but bear in mind that the new emerging picture of the human genome is that each of us harbors about 20,000 structural and copy number variants, either insertions or deletions, or more complex rearrangements. and that typically we see only one or two on a chromosomal microarray. So when you see a rate of 55%, that's still that's compared with this knowledge that there are about 20,000 events, most of which you cannot see using chromosomal microarray. So genomes are becoming the gold standard tool for analysis, irrespective of whether this is a large or a small variant. This is the system that we are building for management guidance. So one of the things we found as we have decoded a couple of thousand babies' genomes is that physicians generally are unfamiliar with the diagnoses we return and don't really know how to manage these children, and are very dependent upon consultation with subspecialists to translate a diagnosis into a treatment, and that's not always possible in time. And also it means that the baby would need to be present in a regional medical center in order to have access to those subspecialists. So most babies, as you know, are born in frontline birthing hospitals where those pediatric subspecialists are not available. And so we built out this system to kind of level the playing field and allow all pediatricians to be able to practice to that level, to upskill them for rare, rapidly progressive genetic diseases. And so again, using AI, we surveyed the world's literature. We assembled a set of 600 or so diseases which present in infancy, result in intensive care unit admission, and for which effective treatments are available. And we've now built this out using expert consensus so that it is authoritative. On the right, I'm showing diseases which are currently featured. There's about 200 of them currently. And on the left, you can see the filtering aspect of going from the world's disorganized medical literature to management guidance. And the vast majority of these diseases don't have any clinical studies, any randomized controlled clinical studies. The vast majority of the treatments have not been reviewed by the Food and Drug Administration. And so this world is absolutely disorganized and really explains why physicians struggle to know how to manage these conditions. So at the end, I'm showing the data here for the first 150 diseases. We've retained about 550 interventions, which appear to be effective. And you can see the breakdown in terms of surgeries, diets. Very often these diseases are amenable, such as the case I just described, to dietary supplements, drugs, devices, and others. We have not yet reviewed any genetic therapies. These diseases that are covered to date don't include any of those conditions, but we will be adding these curative gene therapies in time. So I just described for you a new way of practicing neonatology that we think is poised to move into obstetrics in the future, which is where the genome really drives prompt diagnosis and informs management guidance. And this is not really a test. This is actually a healthcare delivery system that involves a lot of education of clinician teams at each institution so that we have champions who can drive this. It requires hardwiring into the electronic health record. It does involve the testing component, and right now we perform such testing for 70 children's hospitals in North America. It includes the management guidance, which I've just shown you. And then the bits that we're now building out are to actually use the evidence and case series and the follow-up of those children to actually build out underpinning databases, which in turn will inform therapeutic innovation. As I said, only about 600 of the 6,000 known single locus genetic diseases have effective therapies today. So there is a huge need in many of these conditions to identify and develop new treatments, new effective treatments. Okay, let's switch gears. I want to look quickly at a randomized controlled trial where we expanded what I've just shown you and applied it to 213 newborns. So they were all in an intensive care unit with a variety of conditions for which we did not know the triggering etiology. They all received genome sequencing shortly after admission. And we examined in this study both clinician perspective and parental perspective of clinical utility. So between 21 and 46% of the babies received a genetic disease diagnosis. There were a couple of groups within this. Overall, though, physicians found overwhelmingly that those diagnoses had clinical utility. In about 2/3, it changed the acute management of the baby. And in almost 40%, it changed the outcome in the physician's opinion. That is a quite remarkable finding and shows why this is revolutionary. At the outset of this study, we had concerns that maybe parents couldn't handle genome information, that it might result in anxiety, that it might interfere with communications with clinicians. Those fears turned out to be unfounded, and parents overwhelmingly found that the testing, genome testing, had clinical utility, was beneficial to their infant. More surprisingly was the power of negative genome results. 72% of physicians said a negative test result was clinically useful. It helped them refocus on non-genetic causes of a child's illness. It allowed them to navigate from all of those things on a differential diagnosis that they were worried about to other causes. And it often also, not often, but sometimes it changed management. They were being empirically treated for a genetic illness. And in some cases, it improved the outcome of the child. That's a whole aspect of genome testing that we need to think through more fully. When we asked parents the same questions, they had an even more impressive response. The vast majority of parents felt that having a normal genome, so being unable to find a genetic disease trigger for their child's illness, was beneficial. Going from that one study to the world's literature, we find a high degree of unanimity with these findings. You can see here the diagnosis rates across 20 studies and the clinical utility rates and the changes in outcome measures. So 37% is the weighted average for diagnostic rate, 28% for clinical utility, and 16% for change in outcome. The results are getting better and better because over this 10-year period that these studies cover, genome testing has become much better than it was hitherto. So let's just, for the last few slides here, shift gears and look into what this means for maternal-fetal medicine. And so we took that same study, the INSIGHT 2 study of 213 infants, and said, what proportion of those children had abnormal prenatal ultrasounds? So 80 of them, we had that information, so they were seen inside our system. We found that 21 of the children, 21 of the 80, were diagnosed with a genetic disease, so about 25%. And of those, 14 had anomalies detectable on fetal ultrasound. 59 had negative sequencing results. 33 of those had anomalies on their ultrasound. And so when we synthesize that, what we find is that the diagnostic yield is higher in that subset who have fetal anomalies than the whole cohort. This has quite profound implications. It means that triggering a genome sequence predicated on fetal ultrasound, rather than waiting to birth and admission to an intensive care unit, would have a fairly high diagnostic yield. We looked then at particular organ systems that were affected to see, was there some subset of babies that were enriched? And you can see the results here, that there were in several situations that were highly enriched. For example, if there were anomalies in the extremities, if there were multiple anomalies, these were considerably enriched in terms of the odds of having a positive genetic test result. And then just looking at some of these specific findings, these are some of the disease states and the fetal phenotypes. And what's impressive to me is the variety of these. It's not one thing. There are a wide array of phenotypes and a wide array of genetic conditions. Now, this is only a very small series, and so I anticipate that the power of this method will get much stronger. As you are probably aware, our human phenotype ontology has a very restricted list of fetal phenotypes that are represented. And we haven't yet really trained our AI tools to really focus in on those and translate into genetic disease diagnoses. And so I foresee over the next 5 years that we will do additional studies and start to increasingly use more powerful AI that's trained to detect anomalies on fetal ultrasound and translate those into terms that can then help us find genetic diseases. Obviously, the ones that we're really looking most for are things for which we have either an effective therapy that could be started in utero, or those where we know that the prognosis is uniformly hopeless and where we can consider an approach to palliative care or termination of pregnancy if that's what the parents choose. And there is one really exciting diagnosis in here. There's pyridoxine-dependent epilepsy. This is a little boy who had ventriculomegaly on his fetal ultrasound. He presented to us at about a week, 1 week old, with epileptic encephalopathy, similar to the child I just showed you. And we were able to diagnose him within a day or two and start him on high-dose pyridoxine and a modified diet. His seizures stopped. He's not had a seizure since. He's now about 3 years old, and he's doing well. We will have to see what his neurologic performance is. It's still a little early to tell, but that's certainly a case where had we diagnosed him as a fetus, we would have given mum pyridoxine supplements. And we may well have been able to avoid that admission entirely. And that's really us here. Can we start to move effective treatments into late second trimester, early third trimester? Can we start to have precision fetal medicine? Can we start to have precision guidance in terms of when to deliver the child and in what setting? What services should be available at time of delivery? And so this is really the promise, and this is sort of my closing thought about where we're going as a community. We want to avoid waiting for children to become critically ill. Much better to be able to do this during pregnancy. It avoids us having to do this Herculean task of a 13-hour genome. We can actually batch these. We can take 5 days or 7 days to return results, so we can do it much less expensively. And then this whole idea of precision maternal-fetal medicine and precision obstetrics is hugely exciting. Now, in the future, we would love to be able to do this using a maternal sample. That's just not possible right now. It would be too costly to do so because of the proportion of fetal DNA in maternal blood. But it is certainly possible by amniotic fluid, amniocentesis, and decoding the genome of amniotic fluid. And we've done a small pilot of this and found that there's very, very low levels of maternal cell contamination, and that would not preclude us being able to diagnose babies in utero. So I'm really looking forward to the next 5 years as we start to pilot this. And ultimately, we should be able to do this based on maternal cell-free DNA. So we are gradually now implementing this across the first world. It's now policy for infants and babies in intensive care units to receive a rapid genome in Wales and England and Germany and Australia. And in the US, we are gradually moving healthcare systems to do so. And there are now some state Medicaid projects to prove this out in the Medicaid population. So we would anticipate that over the next several years, this will become standard of care in North America, as it is starting to become standard of care in those other countries. So final slide, rapid genome sequencing is being implemented to guide the management of children with single locus genetic disorders. The indication is really any critically ill child who has a disease of unknown etiology. Our understanding of what that does is becoming clearer. And I haven't had time to show you, but cost effectiveness data shows that this actually saves Medicaid money. So inclusive of the costs of testing, it's actually cost saving. And in the future, we can look for this to migrate either to newborn screening or indeed to fetal testing via initially amniocentesis. Those are two little babies on the right who both benefited from this. Sebastiana on the left has Ohtahara syndrome. Riley has infant onset Parkinson's disease. They both received an immediate diagnosis by genome sequencing, and both are thriving. So lastly, let me acknowledge the many people who did this work, and highlighted in yellow are those who did the work related to infant mortality and prenatal diagnosis. Thank you very much.
Okay. Thank you very much, Dr. Kingsmore, for your really interesting talk. I think that was fascinating. I found it particularly fascinating because in England, we've just launched our rapid fetal exome sequencing service in the National Health Service, our public health service. So what you were talking about and the use of AI to help us interpret data, particularly in a prenatal setting when you really do want things to be turned around fast, was really quite exciting. So we've got a few questions. So I think I'll start off by asking questions and we can then see how we go with our discussion. So the first question comes from Polam So and she asks, for the use of AI, do we build a big database and train the computer to match the phenotype, genetic and finding and diagnosis and treatment rapidly? So what's the role of training computers?
Thank you, Lynn. Thanks, everybody. Please keep sending in questions. We got a chance to see this one ahead of time, so that's especially useful. The bottom line, Polam, is that we don't have enough data yet to truly be able to do a good job with AI, that we need very large data sets. So I think what we're doing right now is prototyping methods, and we're using mainly rules-based AI, so Boolean logic, that type of thing. But our goal is to use that to instruct us, to refine our methods, strengthen them, and then do exactly what you're referring to. So get big data and allow the AI to sing the way it can.
Great, thanks. So the next question is around phenotyping. So when looking at the EnSite 2 data retrospectively to explore the likelihood of a diagnosis, did you limit the phenotype information to what was known in utero? That's from Billy Lianglu.
Yeah, thank you. Yes, so that's exactly right, yes. So EnSite was designed to test postnatal hypotheses. And so the retrospective arm, we went back into the medical records of mum and baby to see what was present prior to delivery. And given that this was a post hoc analysis, It's not like there was any special data collection prior to delivery. And so we were very much limited to what was recorded in the record, the maternal record, in terms of phenotypes. To do this prospectively, obviously, we would have had a broader net. We would have been really focused on marginal findings and not just what we would typically, in a routine clinical setting, put in the record.
Of course, one of the things there with prenatal ultrasound or prenatal imaging, because I don't think we should limit this to ultrasound, I think we need to consider MRI and other modalities, is that the phenotyping isn't obviously as good as you're going to get postnatally. But just a question from me, have you looked at using the prenatal phenotypic data in combination with the postnatal data, and does that influence outcome?
Yes, it's a great question. And just let me just tee off, because you said something very interesting at the start there, Lynn. So Peter Robinson right now is working with Ron Wapner to actually create HPO terms, human phenotype ontology terms, for fetal phenotypes. And hitherto we have had very few. And so we right now have a problem that even if you do have fetal phenotypes, there may be no HPO connectivity. And in turn, online Mendelian inheritance in man and OrphanNet are gold standard sets for what are the phenotypes associated with this genetic condition, have definitely not caught up yet, so that these are recognized phenotypes for that genetic disorder. So in some ways, we need to build this science from the ground up. And just because we get deep phenotyping does not yet mean that we have a vocabulary for it, or that we've connected that to the genetic disease literature. So lots to be done. So your question, are we, so within those limits, the answer is yes. Now, obviously with something like congenital heart disease, we have postnatal findings which are incredibly different than fetal ultrasound because we've changed the circulation and so on. And so our ultrasound findings in terms of congenital heart disease or say brain imaging studies, you know, are replaced by better studies we do post-delivery. But things like oligohydramnios, polyhydramnios, other findings, very useful. And in fact, one of the most powerful predictors of infant mortality we found associated with genetic disease is polyhydramnios. So we are finding some very interesting findings in terms of fetal phenotypes which have prognostic implications as well as diagnostic implications.
And the other consideration here, of course, is that we are also beginning to recognize the fact that the prenatal phenotype may be very different from our knowledge of the postnatal phenotype. So, for example, we had in the PAGE study, we had a fetus which had Sotos syndrome, but we didn't report that prenatally because this was a baby that had IUGR. And it wasn't until that baby was 1 year of age that it developed the typical facial phenotype and the larger head associated with Sotos syndrome. So I think the other thing is we may be confused. And in fact, teaching the computer may be quite challenging by the fact that some conditions present very differently in the prenatal period or have a very variable phenotype in the prenatal period. And it's not what we might expect.
Yeah, I would just add one thing to that, Lynn. I would encourage us to think of the perinatal period, because a brand newborn is only hours removed from, you know, prenatal. And we see exactly the same thing. So we find that newborns have very different phenotypes than infants approaching 1 year of age. Kabuki syndrome is a great example. Our Kabuki babies, it turns out, is one of our most common diagnoses in congenital heart disease, believe it or not. And none of them have the Kabuki features. They haven't had time to develop them yet. So the idea of a perinatal phenotype set, I think, is going to have a tremendous value where, you know, the dividing line about the birth canal, we got to get a little bit out of that and think about it on both sides.
Oh, so more collaboration between the fetal medicine doctors and the neonatologists to look at the emerging phenotype of these conditions is going to be critical, isn't it, for interpreting the findings. So let's get on.
Sorry, just one more really quick.
No, keep going.
So Lynn and I had this great chat like this, boom, 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 before you all got here, and you missed it, sorry. Can never be done again. Yeah, and the thing is, we got gestational age in here, right? So the fact that the baby's born is not a time point, it's this range. And so we got this, so that's the other factor. We're talking about gestational age around the perinatal period.
Yeah, it's a continuum. So there is one more question, and please, people listening, do post more questions if you have them. The fetal phenotyping may be limited by lack of functional information. So would you like to comment on that? That's another one from Polam.
Yes, I don't have so much to say about that because I'm not a fetal medicine specialist. But yes, I think the onus is on your community to think hard about how to deep phenotype. And I do think you want to reach out broadly. It does strike me that there's a ton of prenatal information which is not being captured and quantified in ways that could result in phenotypes, like heart rate instability, just one, but so many metrics that you measure, and then that data is actually discarded rather than being folded into a set of quantitative phenotypes. And what we have found in the postnatal period is that deep phenotyping gives us better diagnostic rates. That even though it may seem subliminal to humans, that does not mean that a machine doesn't recognize that and add weights to its Bayesian priors and posteriors.
So one of the arguments here then is we need more normal data, don't we? Because in order to recognize the abnormal or those things that are out of the normal spectrum, we need a lot more normal data, whether it's heart rate data or heart rate patterns or fetal movements or whatever.
Totally. And to put those raw data files into machine learning is the key, rather than to just limit yourself to the findings which were read out in a clinical report based on that study.
Yeah. And because we lack all the developmental information in a fetus, or the development, the intellectual development and sight and hearing and things like that. So we need to be working on other things. There is another question now. So what is the diagnostic yield of rapid whole genome sequencing versus rapid whole exome sequencing? In other words, how often, this is a good question, how often do you find a structural intronic variant within a couple of days with your current pipeline?
It's a super great question. And, so there's the prosaic answer, which is right now, cross-sectionally, in this moment in time, there's not a lot of difference. But then there's the more elegant answer, which is we want a complete genome data set because we're trying to build a new field. And the only reason that exomes exist is a price differential. And so, yes, there is one, but it's getting smaller and smaller. And the power of the non-exonic genome to inform our analyses is skyrocketing. And so if you buy into exome, you have actually bought into yesterday's technology. And as researchers, that's not what we want. We want data sets that can build into the future. It's kind of like folk who only had formalin-fixed paraffin-embedded sections and now realize that DNA is degraded. Oh, how I wish we had frozen tissue. It's the same with genome and exome. You got to get a genome, or you got to archive your DNA in a way so you can, in the future, turn your exome into a genome.
Well, that was a great discussion. I know we've still got 3 minutes left. I don't think there are any more questions. So much as I would love to carry on with this discussion, the next session is the results of the total trial, which is in utero interventions for congenital diaphragmatic hernia. And of course, actually, the work that we're talking about here in sequencing fetuses will ultimately lead to more interventions, be it stem cell replacement, various medications to the mother, as we heard in a talk earlier in the conference, or gene therapy. All of this is counting towards in utero therapy, but I would urge you all now to dial off from the discussion that we're having here and join the total trial. And I'd like to end by thanking you very much, Dr. Kingsmore, for an extremely interesting discussion. And I've really enjoyed talking to you, and I will be in touch so we can continue our discussions and hopefully work together a bit. So thank you very much indeed. Thank you, everybody.
Bye-bye.